Hi guys, welcome to this evening's webinar. My name's Mike Butcher and I'm going to be your host, I guess, for the evening. So thanks for joining us this evening. It's me and my colleague Catherine Forch. Catherine is a concussion physiotherapist. And the plan this evening is just to kind of give you a bit of an overview of concussion, some of the challenges I think with diagnosing and treating concussion in a community setting, and then talk a little bit about some of the things that we have seen change over time with the treatment of concussion. So that's kind of the plan. We're going to try and keep it pretty tight to an hour. I'm going to talk for the first half, and then Catherine's going to come and talk for the second half. So I guess the first thing is I'm just going to spend some time talking about concussion sort of fairly generally, and I guess set the scene around the problem and how big the problem is in New Zealand and where we might see it. I just want to spend a little bit of time just before we get going talking about what concussion is and what concussion isn't. So I think it's really important to understand that it's a type of brain injury. So I don't really like it when people talk about things like head knocks and these sorts of things, because it feels like it's not really taking the problem seriously. But by the same token, it's not a complete disaster. The second thing is it can create a range of different signs and symptoms. So the way that a concussion presents in one person can be quite different to the other. But it's fair to say that people presenting with headaches, things like dizziness, these are very, very common symptoms. But it can be hard to diagnose because the symptoms can be quite subtle sometimes, they can be a little bit vague, and sometimes they might not be immediately apparent. So someone might be upset or very engaged in the game that they're playing on, and these symptoms then evolve over a period of hours and very occasionally days. The next thing is that it is almost always transient. So these symptoms are something that generally get better. And so people that have prolonged symptoms or people that have symptoms that get worse over time are a bit of a yellow flag or a red flag. And we really need to be trying to decide, is this person still suffering from a concussion, or is this a different problem? And we'll spend some time talking about that in a minute. And then the last point here is it's a functional disturbance. So it's something, there's nothing to see inside the brain. So it's like when your computer stops working. I'm sure if you open it up, it would look the same as it did before. It's just the computer is not booting up. It's not doing its normal things. And so that means on scans and things like that, there's really very little, well, there's almost nothing to find unless you use very specialized sequences. Some stuff that concussion is not. And so I think that I sit right in the middle and kind of a moderate, and it sometimes is hard to talk about concussion without sounding like a concussion denier or someone who's getting too worked up about concussion. But I think the media would have you suggest that concussion is terrible and it creates these long-term impacts, whereas some behaviors or the kind of more old school approach was that concussion is no big deal, you should just toughen up and keep going. I think the reality is it's somewhere in between. Some things that concussion is not always associated with loss of consciousness, that's about 10%. So if someone's had a loss of consciousness, that implies a more significant injury. It's not caused by hit to head in most situations, so it's a force that gets transmitted to your brain. So if you get hit in the chest and you have a whiplash type movement, that can create rotational forces in the brain and create an injury. And then things like mouth guards and headgear, they don't really help. So they're often marketed as a way of trying to limit or prevent concussion, but there's very tenuous evidence to say that either of those things help. And this last point we'll go into a little bit later. I think the perception is that if your kid has a concussion, then that can be a very significant lifelong problem. And potentially it is for some people, but that is the absolute minority in my opinion. And I think that that's borne out in the literature or the science. The next thing that's interesting to talk about is how big is this problem, because I think the stats that we have show that what we see in the ACC data, for example, is the absolute tip of the iceberg. And if we have a look at ACC data, they say that we have about 22,000 concussion claims a year, spread across a range of different sports. Sport is about 20% of most concussions in most countries. But if you look at where concussions or some of the problems around creating that data, we know for sure that people don't report concussions. And so some interesting New Zealand data that if you're Māori or Pacifica or you come from a low socioeconomic area, the probability of you reporting a concussion is quite low. And if you have a coach who's a bit old school or a bit of a dick, the probability of you reporting a concussion is also pretty low. So we know for sure that the number that we capture in the ACC data is definitely lower than the actual number. The second thing here is a little disappointing. So physiotherapists are not allowed to use a concussion code. So if we look at people coming to our clinic who have a diagnosed concussion, and ACC is paying for their concussion treatment, about half of them don't have a concussion code. So that means even people that ACC are paying for a concussion treatment are not being captured in the ACC code. So that alone suggests that maybe that 22,000 should be 44,000. And then you add in things like the lack of reporting and a bunch of other barriers, then I would say this problem is a much bigger problem. Another interesting thing is that there's this perception in New Zealand that concussion is a rugby problem. And I would say that's largely because there are quite a few concussions in rugby. We can't get away from that. But rugby is the sport that's done the most to kind of increase awareness and actually do something about trying to manage concussion. So they've been very good at promoting a management plan and actions around concussion. But if you're looking actually where more significant head injuries come from, they're from things like cycling, skateboarding, equestrian, and free play. Those are the types of sports that are much more likely to see you present to hospital as a pediatric patient or a child or adolescent. The other thing that's I think interesting about rugby is that when you play club rugby or high school rugby, you'll typically train, I would say, doing contact once a week, and you'll play one game a week. So you've got essentially 2 opportunities to be concussed each week. If you compare that to football, the data says that you're about 3 times more likely to get concussed playing rugby than playing football. But I would argue that there's a far greater number of exposures to concussion in football. So my kids play football in kind of like kids academies. So it means that they train just an absurd number of times, in my opinion, but they train about 3 times a week. They often will play at school and then they'll play in the weekend. And so it's not hard to say that maybe they might play football 5 or 6 times a week. And so then if you think about the exposures, there's 3 times as many exposures, and you could argue probably that the risk of getting injured is probably about the same in football and rugby. The other thing that's interesting is that historically anyway, a lot more women played football than played rugby. And so we know that women are probably more likely to get concussed or more likely to report concussion symptoms. So again, it's like, well, is rugby a big problem here? I would say rugby is certainly a problem because it's very popular and people play it, but this, in my opinion, is not a rugby problem. The other interesting thing is that at the same time that rugby and football and codes are getting a real hard time and people are looking very closely at the behaviors of those sports around concussion, we've got a whole range of other activities like MMA, which are suddenly more popular than they've ever been. So kids are doing MMA, adults are doing MMA, and the whole intent of these sports is to inflict a head injury. So it's an interesting contrast between sports that are under pressure because they are perceived not to be doing enough about concussion and sports that probably need to have a little bit more of a think about how they manage head and brain injuries. I'm not judging MMA. I'm not super into it myself, but it's just an interesting observation. I think one of the other challenges is it can be quite hard to diagnose concussion. So we typically use tools like this. So this is a tool that's designed to identify concussion in sport. It involves asking players about symptoms and the severity of those symptoms. There's a checklist followed by some memory tests, some balance tests, some coordination tests. And at the end of that, you have to make a determination about whether you think someone has sustained an injury or not. Here's a pretty live example of one of the players I look after at the Warriors. So we get the summary of their score. And so at the top, you'll see that there's a symptom score. So there's a symptom score, which is the number of symptoms that they've reported out of 22. And then they have to rate each individual symptom between 0 and 6. So 6 is the most severe, 0 is the least severe. So you'll see that the symptom score at baseline, so before they were injured, was 1, and they rated that one symptom as being 1 out of 6, so pretty modest. Whereas then after the injury, they've recorded a symptom score of 8 and a symptom severity score of 13. So that's increased. And so that is suggestive in the context of a head injury or a reported injury mechanism that they might have had a concussion. But then if you look at the results in all other parts of their test, their memory scores, their coordination, their balancing tests, all these things are at their baseline value, or in fact better than their baseline value. So these tools are kind of helpful, and they do structure a way of reporting. And if you're thinking about ways to try and identify concussion in your populations or your school, these tools are definitely good to use, but you need to understand that they're not a pass or fail metric. They're a way of trying to identify whether these things or whether these symptoms exist. And so completely free, these can be downloaded online, and I think a really useful resource, but it's important to understand what they are and they aren't. The next thing is this is in the NRL. So I don't know if you guys watch the NRL, but you'll often hear something about the bunker getting involved with the independent doctor, or they'll talk about category 1 or 2 signs, or they'll talk about someone being removed for an HIA or head injury assessment. And this list is what people call category 1 signs. So if these things are seen either by me looking at the field or the independent doctor looking at video replays, they will radio me and say this player must come off and must not go back on. And so if you read down this list, there's some pretty kind of fairly heavy things. So having a seizure, having motor incoordination, which means it's when they're sort of staggering around. I'll show you a video of that in a second. They're things that are not generally considered to be pretty subtle. But if I hone in this motor incoordination, and show you a video of 3 guys getting injured, just if we sit and just watch these. So the player on the ground there from South, so the green and red player, clearly is not normal. So there's clearly something wrong with him. He's having issues getting up. And that is a fairly common sign that we get with concussion. Next player, again, can't get up. Now, the last one I really want you to pay attention to, because it's quite obvious, but very quickly this player kind of gets his balance and kind of gets back moving again with the help of his physiotherapist. So this is motor incoordination. So if we see that, or that gets seen on the video, that is considered to be a category 1 sign. The player has to come off. But almost always that player will walk from the field. They will not remember anything of that trauma or that incident. They'll come into the dressing room, I'll do a head injury assessment, and they will pass that. They'll be at their baseline. So the difficult thing here is if you don't have the benefit of a video replay and you're not watching carefully, it can be easy to miss that, particularly if it's very transient. And the other thing is if you take that person to the ED, or you take them to see a doctor, and they go through an assessment at the clinic, that assessment will not pick this up. And so it's really important that this information is relayed to the GP or to the nurse in the emergency department, so that they are able to make an accurate diagnosis. So even in these very gross and obvious situations, it can be very easy to miss the diagnosis. If you look at NRL statistics, this statistic comes from the NHL, so National Hockey League in North America. And it says that if you look at concussions that are diagnosed in the NHL, about 50% of them are obvious and easy. So it means that the layperson sitting in their room are able to diagnose the concussion based on something obvious happening during the game. And so I think at a community level, we should be really working hard to make sure that these concussions are identified and that the process is applied for these people. So I think if we're not doing that and it's obvious, then we're failing sporting participants. Flip side is that half of them are not obvious, and so using tools like the SCAT that I showed you before, engaging with doctors and physiotherapists and other clinicians that are interested in this particular problem, and just having a high level of suspicion, I think then helps you identify the other 50%. And the whole thing around, you probably read around recognize and remove. So if you suspect someone might have had a concussion, take them off, have an assessment, and prevent future harm. And this last point, if you think you saw something, you probably did take action. So if you identify the concussion, then something has to happen next. And so one of the things that I find that again you'll see a lot in the media is around concussion protocols. So such and such has had a concussion, they're following concussion protocols. And so in the NRL, the minimum time that you'll miss is 10 days. So if you have a concussion, there's a mandatory stand down for 10 days, and that 10 days is entirely arbitrary, and it's designed around the optics of a player missing 1 week. If the player's under 19, then they have to miss 19 days. Again, completely arbitrary number, and that's around missing 2 games. And so it's miss 10 days and 19 days and return if you're symptomatic and you followed a graded return to activity. In community sport, we've recently worked with ACC to develop a national return to play policy. So there was a lot of confusion. So if you look at all the sports in New Zealand, they all largely had their own policy around return to play. And it was incredibly confusing for participants, but also confusing for doctors and people trying to make sensible decisions about return to play. And that was probably best illustrated by rugby, who had one issue at an elite sport, another stand down for senior rugby, 21 days, and then a 23-day stand down for junior rugby. And so now there's a standard stand down for all sports at 21 days across recreational sport. So I should say it's 21 days and they have to be asymptomatic. They have to progress through a graded return to activity and have a medical clearance. So there are a lot of people, as we'll hear from Catherine later, that are still symptomatic at 21 days and are not ready to go back. Again, pretty arbitrary stuff, but the idea is to try and make sure that the majority of people have recovered before they return to sport. The kind of protocol that we endorse is something like this. This is from football. So the first phase is to take it easy for a little while, let your brain recover, and then start progressively increasing physical and cognitive activities. And getting back into a normal routine is really important. So from a kind of like high level sporting context, it might involve resting for a day of light aerobic activity like riding a bike or running. Then the next day is running at a high intensity. Then it's maybe adding in some team drills and resistance training, lifting in the gym. Then often it will be a medical clearance and then a return to contact training and a return to play. And the idea is to try and stage that out over a 14 to 21 day period so that if people are going really well, they've been able to test themselves at various different levels. And a key point is obviously trying to get back to school or work before they get back to football or other activities. And another key point is it's really important to start doing something early, even if it's aggravating your symptoms a little bit. And Catherine will talk about that. One thing to bear in mind is it's quite hard to know when people have recovered properly. And so we use this measure. So clinical recovery just means that the patient feels like they're back to their normal self. So they have no or their normal level of symptoms. It's quite common to have a few symptoms, like some people might feel a bit fatigued if they're studying for exams, or they might have a sore neck if they've been sitting for a long time. These things are normal. They'll have a normal clinical exam for them. So again, in our rugby league cohort, there are a number of players in our team who've had cervical fusions. They've got very stiff necks, and so it's normal for them to have a bit of neck soreness or stiffness. So you need to think about that in context. And then they have to complete that graded return to play. And so if they're able to show those three things, generally, we'll look to start getting them back into work or back to playing sport. The thing we need to keep in mind is, even when we reach that criteria of clinical recovery, about 30% of people, if you look closely, they have some form of measurable cognitive impairment. And the way that we measure that in our clinic is to use something called a cognogram, which is a computer-based neuropsych test. So it's like an old school computer game where you show the patient some playing cards and ask them to react to whether the playing card's flipped over or not. It asks you to remember whether they've seen this card before. And so based on that, you get a score that's based against population norms. And you can kind of make a sense for, compared to normal people your age and gender, where do you sit next to the common man? And so that can be really useful. The best way to use it, though, is how we use it in professional sport, which is we ask the player to do these tests in the preseason, and then should they be injured, you can compare that score with their pre-injury score. And so that's something that's widely used in Super Rugby, NPC Rugby. It's used in the A-League, it's used in the NRL. And we've started using this quite a bit in our clinic. So we either use it as part of the return to play testing process for patients that are going back to kind of more high risk activities, but we also offer it as a baseline service. So we do this en masse for some schools and other sporting organizations, but also some people will contact us, record a baseline, and then they go back to their normal activities. So that's a really useful tool for when people have recovered from their concussion, or we think they have, to try to determine whether that actually has, whether their recovery is complete or not. And it just adds, we know that people that go back too soon have a higher risk of injury, both concussion and other types of injuries. I don't know if you guys saw this yesterday, but this illustrates a definite problem. So these sports have got all these different protocols and processes. We have a range of measures and objective data that we can try and use to help make good decisions. But if the players don't engage in that process, then it's very hard to be certain that they do or don't have a concussion. And certainly this is a persisting issue, but I would say in the time that I've been working in professional sport, there's been a huge shift in how people do and don't report. So there's still no doubt under-reporting, but nothing like it was a decade ago or 15 years ago. Another thing I think to consider is the return to play process I outlined before is a very generic process. So I think when you see people who've had multiple concussions over a course of a season, you need to ask yourself, is this protocol, the 21-day stand down or the return to play process, is that sensible for all of our participants? And I'd say the more concussions you have and the shorter period you have those concussions in, the more you need to start thinking about, is this a sensible approach to follow 21 days? And there are a range of things that we can do to try and make better decisions. And one of the tools we have available to us is engaging with a neuropsychologist. So a neuropsychologist can conduct a battery of tests that allow us to identify whether there is any persisting cognitive impairment, and then to see whether that cognitive impairment is consistent with a traumatic brain injury. And so sometimes we'll find patients maybe present with their fifth or sixth concussion, but they test above the 95th percentile in these cognitive tests. And it can be incredibly reassuring and empowering for these athletes. Similarly, sometimes they'll feel asymptomatic, but you'll find that they test very poorly. And that's not something to say, well, look, you should never play rugby again, or you should not play rugby league or motocross, but it just allows you to have a conversation and empower people to make their own decisions.
Just on that, Fulch, sorry, this is a
Yeah.
timely quick question in the chat. Are there
Great.
any safe recommendations for how many concussions in a season or career is acceptable?
So I would say the answer is no. It's one of those, you kind of, common sense would suggest that having lots of concussions, or the more concussions you have over time, the more careful you should look at whether playing rugby, motocross, or whatever is sensible for you. The way that I would approach that, I think those people need to be seen in a concussion service and have an assessment and some form of discussion about what their brain function looks like and whether playing sport is a good idea for them, or playing those types of sport is a good idea for them. So the example I would give is someone who might have 5 or 6 concussions, who comes in, is potentially in a really high-powered job. They come in and they test extremely well, and so I'm talking above the 95th percentile across all domains. It's very hard to then feel that that person shouldn't return to rugby if they want to. And so I think it's about trying to get as much information and objective data about that person and understanding why they've had concussions and whether there is any residual impairment, and then making an individual decision for that person. Um, and I think it also is really important to understand that it's different people will make different decisions. So I think with my kids, if my kids had had multiple concussions across a year, I would have a very low threshold to say maybe we should be doing something else. But to other people, rugby, motocross, equestrian, these things are just incredibly important to them. And taking those things away has some, pretty significant flow-on effects. So, is there an absolute number? Absolutely not. If someone is having more concussions over a time, either within a year or over their lifetime, I think that really needs to be looked at more closely to help make that person make a good decision. Feels like there was an incredibly long answer to that question, but hopefully that kind of made some sense. And I guess flying on from that, I kind of wanted to talk a little bit about the longer term impact of concussion, which again, if you look in the media or you watch these types of movies, and it's very easy to come to the conclusion that this is a very significant problem. And again, it's hard to be the moderate in this because if you feel like you're a concussion denier or you're in some way belittling this problem. But I think there's two papers I want to talk about. One is some research that was kind of dramatized in this concussion movie. So basically, there's an increasing number of brains that have been donated to a brain bank in Boston um, from people that have played American football, and there is a clear correlation between the amount and level of American football that someone has played and the probability of having CTE, so chronic traumatic encephalopathy, effectively dementia, if we want to talk it kind of more globally. So if you played in the NFL and you donated your brain, there's an almost 100% chance that you would have CTE. If you played in collegiate football, there was a pretty good chance that you had CTE. And if you played high school football, there was a relatively low chance of having CTE. And so it definitely feels like if you play American football for long enough and at a high enough level, there's a cohort of players that will have long-term neurodegenerative disease. But the thing to be really mindful about is these people donated their brain because they thought they had dementia. And so there will be a big cohort of people that played the sport that potentially did not think they had dementia, that haven't diagnosed their brain. They're still alive, and it's very hard to get a sense for the scale of the problem. But I think it's absolutely certain that some people that play contact sport will develop longer term neurodegenerative disease. The other study that gets quoted a lot is from Scottish football. So a really good study that looked at data from players that played professional football from the 1950s through to I think about the 1970s and compared them with a match cohort of just people from the normal population. And so the headline that's been in the Guardian and other newspapers was there was a 3 times increased risk of neurodegenerative disease in those who played professional football. And the hypothesis is, and no one knows this for sure, is that it's because of heading. And so, in support of that, the goalkeepers didn't have an increased risk of dementia, whereas the defenders who hit the ball probably more than other positions had an increased risk of dementia, 5 times increased risk. So yes, there is this data that shows that if you played professional football, you probably have a 3 times increased risk of developing dementia or other brain disorders over your lifetime. But then what the study also showed, which no one has really reported on, is that you live longer if you play professional football than the other group, which if you live longer, you're more likely to develop diseases like dementia. There was a lower rate of all other non-communicable diseases in the ex-footballers, so you are in other ways healthier, less likely to have cardiovascular disease or dementia or things like diabetes. And what the increased risk looks like is a lifetime risk of 1.5% to a lifetime risk of 4.5%. So it's still pretty significant, and I think it's still important that we let people know about that. But that means still that more than 95% of these ex-professional footballers are not developing neurodegenerative disease. So I think the take home from these papers is that there are a cohort of people that over their lifetime playing professional sport certainly increases the risk of developing neurodegenerative diseases. And probably that is related to concussion, but also repetitive head impacts like tackling, heading, these sorts of exposures. And so I think it's important that we let participants know about this. But I think it's also important to understand that there are unquestionably some good health benefits from playing sports like football, rugby league, other things. So, having kind of diagnosed a concussion, like what do we do next? And there's some data that I think talk about data. I'm sounding a little bit nerdy, so apologies about that. So, this on the left here, concussion recovers predictably within 7 to 10 days in the majority of cases. That, until quite recently, has been the thinking in most of the scientific literature. But if you have a look, actually, we know from better quality studies, including this one from our own clinic, that it takes longer to recover. So if you treat people in a structured, sensible way, applying best practice guidelines, it takes about 6 to 8 weeks to get to the point where 90 to 95% of people have recovered, and that is with effective treatment. So the key take home here is it takes longer than we used to think for people to recover from concussions. In the community, most of our concussion care is delivered by a GP, and there's some problems with that. Typically, it's hard to get in to see a GP, and often GPs don't see a lot of concussion, so it's hard to get comfortable managing concussion. But if it's your first concussion, if things are going quite well, primary care is a really good place to have your concussion managed. And if you can involve a physiotherapist and have some physiotherapy, then GP plus physiotherapy works even better than GP-led care. Just following on from that, the primary care funding models are fine, but short consultations, difficult to get into, and it's a pretty ad hoc kind of interdisciplinary environment. So you might see your GP, they might suggest you see your physio, but the information flow here isn't very good. And so if you have more complex symptoms, it really does take more time, more people being involved, working together, and considering things like return to work and return to sport, I think is really important. Return to work and return to school, I mean. And so when you come and see our clinic, the main thing that we can offer you is time. So we have a different funding model and a different treatment paradigm. So because we have more time, we can spend more time doing a detailed clinical exam. Because we can do that, we can identify the symptoms and treat them more effectively. Because we're working in a team, your care is more coordinated. And because we're doing it all the time, our clinicians are very comfortable managing concussion. So we have essentially two concussion workflows. One is a sport-related concussion where you get injured in the weekend, or it's an acute concussion clinic, actually. It's not just sport. So if you have an acute concussion, we will try and see you that week. And the main purpose of that initial assessment is to say, how are things going? And if it looks uncomplicated, then we'll work with your GP or your physiotherapist in the community to get you back to normal activity. If things are not going good, though, we will refer you into our concussion service for an interdisciplinary assessment where we try and get to see the right person at the right time. If you've had multiple concussions and are going well, that might be a neuropsychologist to do a cognitive assessment. If you have predominantly kind of balance issues, Catherine and one of our physiotherapists might be the most appropriate person. And so it's about saying, look, hey, let's try and be proactive about managing your individual symptoms. And then I guess the best way to manage this is in a team, and our teams are all co-located in one place where we can spend time talking to each other and making sure that our patients are getting better. Whereas a lot of the interdisciplinary teams are contracted out and people are spread all over the city. So it's very hard to say that that is genuine coordinated interdisciplinary care. So I think it's very clear that when people are not recovering well, involving a team is the way to go. Last slide from me is there's a lot of reasons why people might end up in a concussion service or might not get better. And so we use a symptom score called the BIST, which was developed in Auckland. And we get a BIST score out of 160. And there are a whole lot of reasons why people might have high or prolonged symptoms that are not related to the concussion injury themselves. So I think that's a good opportunity to pass on to Catherine, who's going to talk a little bit more about treating concussion and how that might work. So I'm just going to pause and we can swap over.
Oh, while I'm
Just the
pulling these
thoughts.
slides up, perhaps, Fulch, you could
Yep, I'll
speak
have
to
a look at.
Brendan's comment in the chat.
Okay. Brendan O'Neill. The ACC concussions are confusing a medical clearance. Both timing and the checks required. I mostly see ice hockey players after day 14, so I can clear them for stage 5, but most athletes want to be cleared to compete without the stage 5 rehab clearance. Well, without the stage 5. Yeah, it's a very difficult problem. So the idea is that people need a check with a clinician before they go back to contact, and that's to try and prevent the risk of re-injury. What happens in reality is that by this stage, a lot of players get to 14 days, they're really frustrated, they feel really good, they've gone through a graded return to play, and they don't feel the need to have that session. And one of the what is happening, what is coming is that sports are going to treat concussions in the same way that they treat yellow and red cards. So in football, if you get a red card, that gets reported by the referee, and you cannot play until you have served that suspension. And so when sports get their systems to work a little bit better, concussion will be the same, and that will require people to do that return to play clearance. And so then I think that that will change some of that behaviour. So we've just had a meeting with the rugby union, and the rugby union is working towards a program that will allow that to happen, but they're not quite there yet. They had been hoping that that would be rolled out this year, but it looks like it will either be during the year this year or the following year. So it is confusing. The guidelines clearly say that you have to have a medical clearance before you return to contact, but no one's enforcing that, which is the problem. I'm going
All right.
to hand it over.
Cool. Can you see my slides? Are we good?
Can do. Yeah.
Right. Oh, help if I could click through them. Hang on. Standby caller. Yeah, so my name's Catherine, and I'm a physiotherapist originally, and I've sort of ended up in this bit of a niche of concussion. So I do some clinical work with the team at Axis, and I do some teaching in the undergraduate and postgraduate programs at AUT and the University of Auckland. And I just wanted to share a little bit about kind of where we've come from to where we are today. So when we first started treating concussion at Axis, there was 3 of us. It was Stephen Kara, who's a physician, myself, and Hannah, who's an exercise physiologist. And we were kind of rattling around in the old sort of cricket club rooms out in the back of one of our clinics. And now it's an entirely different picture. So we've got 9 clinics across the Motu. We have a cluster of clinics in Auckland, and then we have Queenstown, Christchurch, and very soon to open Dunedin. So things have changed a lot. We see over 1,000 concussions through the clinic. So I just wanted to share a little bit about kind of how we approach managing some of these more complex injuries that end up with our team. We have all these very clever people within the team. So as I say, it started off with 3 of us, and now we have a whole range of different areas of expertise that we can tap into depending on what the needs are for that particular person who's presenting for assessment. I'm also really proud as a complete research nerd, so I'm doing my PhD at the moment, and we have a lot of active collaborations. So we're continually sort of challenging and learning and trying to grow the evidence base around concussion, both in New Zealand and internationally. And we have some quite cool collaborations and some ongoing projects at the moment that I'll mention briefly about. Fulch touched on this one a little bit, but I talk to this quite a lot with my patients. So there was this historic kind of figure of concussions take about a week to get better, sort of 7 to 10 days. But when you unpack that, that was really just based on a bunch of clever people sitting in a room in the 70s decided on that. And it wasn't really based on data. So we published this study, which was on people who had really early access to care, quite young people, and all sports related concussions. So generally, if someone's going to get better quicker, the deck was stacked in the favor of this group. And we found actually that when we looked at getting the majority of people feeling better, it was more around that 4-week mark, and that there was a little bit of a tail. So some people took up to about 8 weeks. We had about 95% of people feeling better within 8 weeks. So I think what that tells us, if you're not young and sporty and reasonably straightforward, and you maybe have other complexity in your life, like I'm a mum of 3 and I've got a lot on my plate at the moment, I think a concussion would not go particularly well. That we should think of recovery in terms of weeks and not days in most cases, and that's really normal. And it doesn't mean that you're going to end up like the guy in the concussion movie that Fulch was talking about. So I'm going to highlight a little bit about kind of the role of the physiotherapist, because that's what I sort of know well. But it's quite cool moment to reflect on the team that I have around me. And so we have a whole range of physiotherapists involved in our concussion service at Axis, and all with their own sort of special interests. And it's really cool having that collaborative approach within the team. So a big part of my role when I have someone in front of me in clinic is that typically what happens with a concussion injury is that it's never straightforward. So it's never kind of a straight line in terms of their progress. There's always these ebbs and flows and challenges. And so it's how do we kind of lift them up when they're in the lows and help navigate the way to eventually getting to that outcome that we're all looking for. So I just wanted to talk really briefly around actually what's happening in the brain during a concussion, because that sort of leads into understanding our treatment approach quite well. The brain's quite an amazing, beautiful, moving thing. And so this is a study looking at the actual movement. This is just with somebody's breath. That's how much your brain moves when you're breathing. And so if we've had a force transmitted to the brain through a concussion, it's actually about the movement of the brain that is the thought now that creates the problem. So it's kind of the wobble of the jelly as opposed to the squishy jelly hitting into the hard box of the skull. And what happens during that wobble is that we get a whole lot of nerve signaling happening in the brain at once. And that's why you might see people staggering, or in extreme cases, they'll be having seizure-like activity, or they'll fall unconscious. And their brain's just literally sending off a whole lot of signaling at once. And I explain that to my patients like a bit of a fireworks display's gone off all at once in your brain. And then after that happens, we have this period where we've burnt all of our fuel up. So the brain's done a whole lot of work at once, and then it has this real period where it's in a bit of a low. And that's often the crash that people experience after concussion, where they can be really, really tired sort of that day or the next day. The other really important thing to understand is that your brain after a concussion is a little bit less efficient. So if you put this is a functional MRI scanner study. It looks at kind of how much of your brain is active during a task. People after concussion, your brain's a lot less efficient. So your brain kind of lights up like a Christmas tree when it should just be quite a specific part of your brain that's involved. And I explain it a bit like someone's tipped your filing cabinet all out on the floor. So it's not lost or damaged. Your brain just takes a little bit more work to find the file that it wants. And again, that contributes to this low energy tank. The other thing that's happening is that the way that we organize the blood flow in our brain is normally really tightly controlled. And sometimes after concussion, we're not as clever at organizing the blood flow in our brain. And so when we have a little bit less blood flow in the brain, but the brain is using more fuel than it normally would be, that contributes to that sort of mismatch of supply and demand. And so that's generally a big cause for a lot of the symptoms that people are experiencing. So in the first kind of 24, 48 hours, this is generally before somebody's seen me, the key things for them, and this is probably a little bit of advice if you've got friends or family members or you're working with athletes, is that nutrition is really, really important. And that first, we've got this kind of fuel depleted stage, so we want to be getting good fuel back into the body. The other thing that's really important is that they're trying to get good rest. So we're trying to optimize the sleep as early as possible after these kind of injuries. And that's the first step towards filling the tank back up. We're also bearing in mind the fact that the brain is less efficient, and so we're trying to reduce the demands on the brain. So it's not necessarily phones, but it could be other things that are very energy demanding. Sometimes that might be really busy social settings, that might be really chaotic work environments, and that first 24 to 48 hours are really just letting things chill out a bit. And then after that, we're going to continue with those foundations of eating well and sleeping, but we start to have a think about addressing the blood flow issue. And one of the main ways that we do that is getting people to start exercising, some type of active rehab very early. It's shown to be really safe. Sometimes it's something as simple as going for a walk, but it can be a really powerful medicine for concussion. And then beyond that stage is when, if that person needs it, they should be rehabilitated in terms of having access to a team that can help guide that. And the way that we do that in clinic is we sort of look at, okay, what's going on for this particular concussion injury at this time for this person. And we have kind of subtypes of concussion. So concussion can affect your inner ear, your vestibular system, so that helps you with your balance, knowing where you are in space. It can affect your vision and how your eyes work together. Sometimes the neck can be involved. Sometimes how you think and your thought processes can be impacted. Some people have changes to their mood. Some people have sleep disturbance, and some people have trouble with their autonomic functions. This is the kind of background things that should just hum along, things like organizing your heart rate and your blood pressure and all those kind of things. And we found that if you start to target the management towards actually what's going on for that particular injury in regards to their subtype of concussion, they get better quicker. We've also found through some research through our clinic that there's a couple of things that can help us guide our expectations in regards to recovery timeframes. So we know that being female can take a little bit longer. We also know that people who are experiencing dizziness can have a higher risk of a longer recovery, and people with a higher symptom burden. So some of those things that Mark cited that make our antenna go up a little bit around this may take a little bit longer for this person to recover. There's some key points that if someone's coming to see me, I want them to walk away with understanding in terms of intervention for concussion. And the first one is those things I talked to you about in terms of the supply and demand, actually what's happened in their brain to do with the injury. And then it's this idea of, you know, this Goldilocks zone of what's an okay amount of symptoms, because the old-fashioned advice of, you know, rest in a dark room until your symptoms go away is not helpful. And actually we do need people to be doing a little bit and a little bit of challenge and then building on that. And so we use something called the +2 rule for that. We also want to pitch our programming and our plan at a level where they're not sort of driving any kind of fight-flight responses. So sometimes the nervous system can be a little bit sort of wired after an injury. So there's parts of your brain that are really there just to keep you alive. And so after an insult to the brain, they can be a little bit more on edge. So that's why sometimes people have sleep disturbance. They can be irritable. They can have changes to their appetite, all sorts of weird and wonderful things like that. The big message for our kind of intervention is we're sort of trying to do graded exposure. So we're getting normal, healthy input to the brain so that it can kind of recalibrate, for want of a better word. And I always say to people, try and get outside as much as you can with a concussion. So artificial lighting, screens, a lot of modern kind of life is actually not particularly helpful when you've had a brain injury, particularly in the early stages. So in clinic, we would be having a look at some of these slices of the pie a little bit deeper. So everyone who comes into clinic will have some type of a graded exercise test, and we look to see if their kind of heart rate responses are what we'd expect them to be in relation to some exercise challenge. And we've shown through, this was Armitesh published this paper, excuse me, I need a coffee, showing that people who have some changes in terms of their ability to get through an exercise tolerance test, that again can help us answer that question of how long it might take that person to recover. We also see a lot of neck issues associated with concussion. So sometimes that's because there's been a whiplash type mechanism as they've got injured, but we are often managing the neck as well. And people can have, as I mentioned, trouble with their vestibular system. So often this will show up as dizziness or feeling like they're unbalanced or a bit clumsy and things like this. We also see people with oculomotor problems, which is your visual systems. So they might have visual strain or challenge, or they might be more provoked with things like screens. And so we'll be assessing that and treating that if needed. And it always comes back to this. So having this ability to kind of think about the subtypes of concussion can give you the ability to sort of take a step back if your treatment isn't going as we'd expect. So all of our team are quite reflective, and we'll sort of we have complex case reviews, and we have the ability to chat through our patients and think, hey, this isn't going as well as I'd expect. Do I need to be considering another angle for it? And then the last part is, what does recovery look like for that person? So Fulch touched on this a little bit, but we are really keen to reduce the increased risk of subsequent injury. So at the moment, if you go back to playing sport after a concussion, you have at least twice the risk of another injury, whether it's a concussion or something else like an ACL tear. So that kind of indicates that there's some people who are going back probably before they're completely recovered. And this is a big area of interest for me. This is what my PhD research is looking at. And so if we're looking at an athlete going back to sport, we're kind of thinking about all the demands on their system that they're going to be exposed to in the sporting arena, and making sure that we've assessed all of those things so that we have a higher level of confidence that they are completely recovered. So just to tell you a little bit about what's going on in terms of some of the studies we have at the moment, as I mentioned, I'm looking at return to play testing and seeing if I can develop a protocol that's helpful for that kind of clearance side of things to increase our confidence that somebody's recovered. We've got the very clever Rebecca Blythe, who's doing some work through her PhD looking at female football players in particular, with their sort of knowledge and understanding the beliefs around concussion, but she's also looking at some of the reasons why female football players will experience more concussions for a matched stimulus. Fulch mentioned this already, but we had Logan, one of our registrars, who had a look back through some of the presentations to our concussion service and found some data showing that the coding issue that Fulch mentioned, where physiotherapists can't diagnose a concussion, is probably meaning that the numbers are very underreported in terms of the scale of the problem. The ACC, there's more concussions out there than they know about. And then, as I touched on, I'm having a look at return to play testing. So I'm doing a big crossover study at the moment. If you have concussed athletes that you know about, or healthy athletes who are interested in participating in research, please reach out to me. That would be fantastic. And equally, Rachel, one of our physiotherapists, is looking at some of our clinical tests and whether they can help answer that expectations of recovery question in terms of predicting outcome. So just to summarize, concussion takes longer to recover than we think. The brain is quite a complex organ, but for most cases, the outcome is generally really, really good. It can be tricky to manage in a sort of primary care setting, so that's where concussion services, fully funded concussion services, can do a really great job with people. And one of the things we love about our team is that it is this very collaborative kind of interdisciplinary approach, and we have a really active approach, and that's really, really important to get people moving early and to start to challenge the system. If someone's having a difficult time after an injury, or they've got some of these modifiers we know that increase their risk of a longer recovery, it's important that that person gets to care earlier rather than this kind of wait and see approach. Thank you. Questions?
There are a few. I've been busy battling away with
Amazing.
the keyboard while you were talking. So I might just scroll back up to the top because I think some of them are probably easier to discuss. So the first one's from Ethan, which is around the need to wake people regularly to check on them after someone's sustained a concussion. So I have a view on that. What do you think?
Oh, well, this is, yeah, it's an interesting one. I mean, obviously, if it's right away, we don't want them to go to sleep because there's the possibility that they may deteriorate. But generally, if it's been kind of like a morning, afternoon sporting game, the advice now is to sleep as normal, and we don't have to be waking them up. Does that align with what you said?
Pretty much. So I guess the key thing is, if you're concerned about someone to want to wake them regularly, I think they should be in a hospital or clinic setting. So most of the time, rather than waking people regularly in the ED, we used to call that neuro-obs. So you check them and basically make sure that they hadn't deteriorated. Most of the time, if you went to the ED, they would do a CT head, make sure there was no bleeding or cause for acute deterioration, and then they'd send you home. And then I think trying to get back into a normal sleep routine and or having some napping and resting in that first day or two, I think is the way to go. So there's quite a bit in the chat here about medication and supplements. So we did a webinar yesterday talking with a range of different clinicians. And so my feeling short term for medication, the best options are just simple pain relievers if you need them. So things like paracetamol or ibuprofen or diclofenac. There's some talk here about supplements, so magnesium, NAC, which is a range of different things, and having a concussion kit with sports teams. And so my feedback is that there's very little evidence that these things will do anything useful for you. Icing the neck. So the Warriors were trying these skull caps. There is a suggestion that by cooling the brain immediately after injury, there might be some benefit. But if I'm honest, I think this is just it's a fad that I don't think we'll be doing next season. And I think that the other thing is that these things I think can be a distraction from doing things that are actually very important, which is making sure that someone is seen properly, that you're getting them off the field of play, that you're ensuring that they've got a plan around how to manage the concussion. And there's nothing wrong with icing the neck, taking magnesium or whatever, but I don't think that that's actually helping. So
Yeah. And Josh McGowan did a systematic review of the literature around supplementation and showed that there hasn't been any studies that aren't produced by the company that's making the supplement. So it's that risk benefit situation, like Fulch said. If you're just taking the supplement and then you're having Macca's and a Red Bull, then that's probably not helpful either. So, that advice around healthy eating, whole foods as much as possible is great. And it's probably unlikely to do harm, but it's questionable as to whether there's benefit. Yeah.
yeah,
And icing the neck, I wouldn't see a huge amount of in terms of concussion. I mean, you will get potentially a little bit of pain relief and distraction from it. So it's, again, probably not going to do any harm, but I wouldn't replace what is recommended care with just those things.
Yeah, the thing that I think that we're very proud of in our clinic is around having evidence-based treatment and excellent care. And so that doesn't mean that we don't try different things. And the fact that we are a research clinic shows that we're always looking for new ways of doing things. One of the things or observations I would have with concussion, because it's quite an emotive thing, because some people don't recover for various reasons, there are a whole lot of gurus that have their own treatment regime, and I don't think that that is likely to be helpful for most people. The other thing is I spoke yesterday about a study, the only study that I'm aware of that looks at creatine in traumatic brain injury. So it compares taking creatine, which is basically an energy source for the brain, and compares it with placebo. And it showed very clearly that both groups had the same level of improvement. So it kind of illustrates that placebo is really effective for a lot of these symptoms. It also illustrates that over time, people with concussion tend to get better. So if I think if you compared icing the neck with some other sort of placebo type treatment, say icing the chest, I think you'd see very little difference. But that's my opinion rather than hard facts. So I'm very aware that we're about to roll over to 8 o'clock, but there's some really good chat here. If anyone has anything else, please feel free to stick it in the chat or the Q&A. And otherwise, I just see something in the Q&A that you've added to around the National Register for Concussions. It's a great idea. There isn't one, but as you said, there is a desire to capture these injuries better. There are registers for other things. So, for example, there's registers for ACL injuries, so we can understand ACL injuries better over time. But these things at the moment don't exist for concussion. And so you have problems with injured in rugby but play rugby league tomorrow. It's kind of like the rugby example of people who trick the doctor with their head injury assessment. It does require engagement with the participant in order to have a shared good outcome. So I think that might be it, everybody. So thank you very much for spending an hour with us on whatever we are. We're on a Wednesday afternoon, I think. So I really appreciate it. Feel free to get in touch. Our email is here. And Natalie, who I forgot to introduce right at the beginning, who is the brains of the operation here, we'll share some information with you early next week. There'll be a link to this if you want to share it with any of your colleagues, please do. There'll be some other resources that potentially will be useful to you. So thanks again, and look forward to meeting and working with you in the future.
Thanks, everyone.
Mhm.
See ya.